Hey friends, this episode of The Fellow on Call is not meant to be used for medical advice and is intended for educational purposes only. Patient information has been modified to ensure privacy. The views expressed in this episode do not necessarily reflect the views of our employers. Enjoy!
Welcome to another episode of The Fellow on Call, the HEMONC podcast. We're coming at you from Rillo University Medical Center. I'm Ronak.
I'm Vivek.
And I'm Dan.
And in today's episode, we're continuing on our CLL journey, and this time we'll be spending a decent amount of time talking about a hot topic in hematology and oncology right now, the idea of MRD, and then also going into a little bit more about some novel combinations in therapy for CLL.
Yeah, I'm excited to get into this one. MRD is something you hear all the time. You hear clonoSEQ, you hear all these things, they sound fancy, but it's not ready for prime time in the clinical setting, and we hope to walk you through that today and why that's the case, and really get you an idea and to have a pulse on what's happening in CLL in the future.
Yeah, it sounds great. Let's do it.
All right, guys, we'll roll that show. All right, y'all, guys, before we start today's episode, I just got up to speed on the latest season of Love is Blind, and let me tell you, this one is juicy. Vivek, I know you're watching. Dan, are you watching?
This is so good.
I am not, but I'm very intrigued. What makes it juicy?
Dan, you have to watch these shows, okay? This is The Fellow on Call. We're filled with trash television. We took a break from the intros with trash television, and before this one, we decided that we got to bring it back. It's really important to bring back the trash TV. So this season, I cannot suggest the season anymore. They've really gotten back to the correct formula of a lot of crazy people, a lot of drama. I don't know, Ronak, how would you describe this? What would you say?
I think what I saw somebody say on Twitter was that there's so much in this season that wasn't on their bingo cards, and I cannot think of a better statement about this show. I mean, people just seemed so normal in the beginning, and their crazy has come out as soon as they got back home, and it is unbelievable. I mean, it is so interesting to see. I happened to be on a layover in Charlotte just this past weekend, and there was a part of me that was like, do I just miss my flight and go out in Charlotte and try to see if I can find these people? Because like, I just need to see if they're like this in real life or if this is just for television. Regardless, I'm totally into it. And listeners, if you're not watching, you need to be watching.
You may or may not find a Megan Fox lookalike. Nobody knows. Nobody knows. You may or may not find it.
I'm afraid to say much more because I don't want to spoil the show for anybody. So before our mouths get running and we have to bite our tongues, why don't we get on with the actual show today? Guys, I think we said that we'd be talking about MRD testing and some additional things that are in the pipeline for CLL treatment. So I think this is going to be another great episode. Certainly we'll round out our CLL series and be another very informative episode for our listeners. So Vivek, do you want to kick us off?
Yeah, I'll kick us off with the case right here. So we have a 68-year-old male with CLL who presents for management discussion. Lab showed a white count of 120, hemoglobin of 9, and platelets of 130. He has clear indications for treatment. He's also symptomatic, fevers and night sweats. He's got some palpable adenopathy, and he's got this anemia, this thrombocytopenia, so he clearly needs treatment. His risk stratification workup with FISH was notable for a deletion 17p, and his IGHV was unmutated. So he has high-risk disease, and this kind of fits in this patient who's very symptomatic. So he comes to us, and he says, hey, doc, I've been reading online. You have this medicine called obinutuzumab, some things called BTK inhibitors, and something called venetoclax. Why not throw all three of these together? What's the advantage of that? What about single-agent BTK inhibitor? What about obinutuzumab and venetoclax? I've also read something about MRD testing. I don't know what it means, but Google told me that it's important. So let's get into all of these with this patient and this patient case. First of all, can one of you define MRD?
Yeah, so we've talked about this a little bit during our HemePath series, and I think in myeloma series as well. But MRD stands for measurable residual disease. You might hear minimal residual disease. I think measurable residual disease is a better, more precise term, because minimal, what does that even mean? Basically, measurable residual disease, or MRD, is trying to say whether or not we can find any small residual cells, cancer cells, in somebody who's been treated, as opposed to disease that is not detectable by our methods. And basically, the idea behind trying to look for the smallest residual amount of cancer, well, it seems obvious, right? Like, is this person truly in a deep remission, or is this just something on the surface level where we can't visibly see any cancer cells when we look at a marrow sample, but maybe 1 in 10,000 when we run it through flow cytometry, there is a couple of cancer cells there. It gives us an idea of depth of remission. And we have those set response criteria based on morphology like CR, complete remission, or PR, which are clinical definitions based on both patients' blood counts and what we see on the marrow. But MRD or MRD negative basically means we can't find any trace with our highly sensitive techniques. By and large, MRD is referring to using flow cytometry methods to try and detect one cell in basically looking for that needle in a haystack, one cell out of tens of thousands of cells. And we also now have some PCR-based techniques that look for things like molecular remission in disease states like CML, others where we can look for a specific molecular signature. But for the purposes of our discussion today, we're looking at flow cytometry methods. So MRD negative, meaning we can't find any trace amount of disease with flow, and MRD positive means we can find a few of those cancer cells with our most sensitive flow techniques. But by conventional morphology, just looking at a bone marrow slide, we don't see any disease there.
It's really important to understand that the utility of MRD in clinical practice is still under investigation. This isn't ready for prime time for CLL like it is in other disease states. As we discussed in our myeloma series, a single time point of MRD may not be as relevant as sustained MRD, the kinetics that you're achieving this MRD. If you look for this too early, maybe that's not a good thing. Maybe you need to look at it, which time point is important. And we still don't have all of the answers for that. We do know that if you're MRD negative, I can't find anything, that's generally a good prognostic sign, right? Not perfect, but it is a good prognostic sign. So always use this testing with caution. And like Dan said, for now in CLL, we mainly see flow cytometry. But Ronak, what are some of the other techniques to determine MRD? Can you walk us through the flow and the molecular techniques?
Yeah, totally. And so, guys, as you may know, historically, pathologists and hematologists would rely on that good old peripheral smear and the morphology under the microscope of the bone marrow to look for any overt evidence of disease. And so cytology alone, so that is looking at those cells, has a sensitivity of about 1 to 100. So it's very difficult to understand the depth of remission if patients are clinically asymptomatic. So if you're looking at the cells with your eyeballs, as Vivek likes to say, you're not going to pick up these trace amounts of abnormal cells in a sea of normal cells if you're just looking at them under the microscope. And so there were attempts to use multiparametric flow cytometry to assess for deep responses, with the first international consensus that was published in 2007. And so a couple of reminders from our HemePath series. Remember that for flow cytometry, you need live cells in suspension. Remember we said anything that's in live suspension, in theory, you can flow. So you need to have those cells that are alive. And it looks for common CD markers that are expressed on CLL cells, for instance. So it doesn't require us to tell the machine what kinds of markers we're actually looking for. So this technique allows for a level of detection of 1 in 10,000 and in some cases 1 in 100,000. And so sometimes you'll see this reported as an MRD4, which is 10 to the minus 4, or MRD5, which is 10 to the minus 5. So that's what that means, basically how granular the flow cytometry is going in order to look for those abnormal cells in circulation. So in 2016, there was a consensus statement that came out from the European Research Initiative on CLL, and they called this ERIC, that validated a reliable detection of CLL to MRD5. And there have since been 2 other techniques for MRD that involve molecular testing that have come about. So remember, we talked about visually looking at this as 1 in 100. Now we talked about flow, which is 1 in 10,000 or 1 in 100,000. And now we're looking at molecular testing as well to go even more granular. So one of these allele-specific oligonucleotide PCRs essentially looked at rearranged immunoglobulin genes, which you'll recall is important in CLL. So this requires patient-specific primers and requires a representative pathologic sample to set up. And this is not yet used in clinical practice. And you can imagine the difficulties in this, right? You have to know exactly what you're looking for because the scientists doing the assay need to know what primers to add so that the PCR machine can properly amplify the region that's of interest. A more common technique that you may see is called ultra-deep next-generation sequencing. And this identifies residual CLL by amplification of all VDJ sequences from a single sample. So to run this test, you need to know the CDR3 sequence of the immunoglobulin expressed by the original CLL clone. And one of the more common versions of this assay that we see is called clonoSEQ, which you may have seen in your clinic or at your hospital. So you may typically see clonoSEQ, which is NGS-based testing that provides a sensitivity of MRD5 or even MRD6. So you can get really in-detailed look at the depth of response and whether or not you see any of these cells. You're looking for like 1 in a million cells in this situation. But unlike flow, the problem here is that there's no consensus. There's no standardization. So again, the question becomes, even if we have this data, how do we incorporate this into our decision making? Other barriers with this test is it requires specialized reference labs, and it's certainly more expensive than like a flow cytometry assay, for instance. So all this to say, as we've been saying already in this episode, these are really exciting things that hopefully will become used in clinical practice in the future. There's a few kinks that need to be worked out before we can standardize this process and incorporate that. So just things to be aware of and things to look out for.
Yeah, this is an excellent summary of that stuff. And really for our listeners, we'll summarize this in our show notes as well. But it's really, each of these tests have a different depth. That whole concept you'll see often in the CLL literature, MRD4, that literally means 1 in 10,000, 10 to the negative fourth, right? MRD5, 1 in 100,000. That's what it means. Often in these studies, we're talking about MRD4. So throughout this series, we've talked about how CLL exists in multiple anatomical compartments. We have the peripheral blood, the lymph nodes, the bone marrow, spleen, liver, so many different areas. And remember, the lymphocyte flare after a BTK inhibitor was a result of the translocation of the CLL cells from the nodes to the peripheral blood. So the big question is, when we're performing MRD testing, do we need to get a bone marrow biopsy on these patients, or is a peripheral blood sufficient, knowing that we have all of these different anatomical compartments?
When it comes to MRD, remember that we're looking for very rare residual cancer cells after treatment. And so there's an argument to be made for looking in the bone marrow because you want these tests to be as sensitive as possible. There is still about an 85% concordance between MRD results from the peripheral blood and MRD results from the bone marrow, and we're talking about MRD4. That's just data from numerous prospective studies and sort of the trial level data from those studies. So we do still use peripheral blood for looking for MRD and CLL, but do keep in mind that it is probably a little bit more sensitive to look in the bone marrow itself. And so thinking about when we actually get to MRD, a lot of rituximab-based regimens typically had higher rates of discordance between MRD results in the peripheral blood and bone marrow. And so it's interesting that there actually may be an interaction with the choice of treatment in terms of what that concordance rate actually is. Obinutuzumab, on the other hand, seems to have better concordance between MRD results in the peripheral blood versus the marrow. And it's not entirely clear why this is the case. This is still an active area of investigation. And this is why we really feel that clinical trials should be looking in both places to try and understand what the effects of these individual treatments are. Because if you're giving somebody a treatment, you need to know where the best place to look for this response is. Vivek, do you want to tell us about some of these earlier studies looking at MRD?
So one of the earliest studies looking at MRD testing was from Leeds in the United Kingdom, and they've done a lot of work in the MRD space and in CLL in general. So what they did is from 1996 to 2007, they looked at MRD and the bone marrow samples for all their patients and said, what happens? And not surprisingly, those who were MRD negative had better prognosis, better PFS, and better OS. Interestingly, if you had adverse cytogenetics like deletion 17p in this study, and you achieved MRD negativity, then you did just as well as patients who were MRD positive but didn't have adverse cytogenetics. The idea was, well, if you deepen that remission, maybe that overcomes the adverse cytogenetic profile. Keep in mind, this is in the chemotherapy era. This isn't in the BTK inhibitor era. This isn't in the venetoclax era. And there's another study from that Leeds group that kind of talked about what Dan said, which really asked, well, is there different concordance between the peripheral blood and the marrow based on what regimen you choose? And they did find there was a difference. And that study, interestingly, it seems that if you had a bone marrow negative patient, that they had the best prognosis, but it wasn't that much different than just peripheral blood MRD negative. So yes, if you had both peripheral blood MRD negative and bone marrow MRD negative, you did tend to have the best prognosis, but it wasn't that much difference than if you just had peripheral blood MRD negativity, despite your bone marrow being positive. So even if there's a discordance, peripheral blood MRD negative state has a very good prognosis, and you don't necessarily need both, and it's more convenient. But like I said, we don't have enough information to make that definitive claim. And the idea behind MRD, regardless of prognosis, right? I mean, I guess that's kind of important, but it's not perfect. It's not a perfect marker there. It's not like, yeah, you're MRD positive, then you're out of luck, right? That's not how this works. The big use of MRD is, can we de-escalate therapy based on your MRD status? So do you really need the bone marrow to do that? And we'll talk a little bit more about that as we go through the discussion today.
So before we go into that a little bit, I actually do have a follow-up question with you all, how you'll manage this in your clinics. So at the end of a patient's treatment, let's say they're on a fixed duration treatment like obinutuzumab and venetoclax, what is your method to determine whether or not they've responded well? Are you just using flow cytometry? Are you sending off these things like clonoSEQ? Are you having everybody undergo a marrow? What is your approach?
So I think it's really interesting when you look at the CLL14 trial, which we talked about, obinutuzumab venetoclax versus obinutuzumab and chlorambucil. When you look at the rates of MRD negativity, we're looking at somewhere in that 65-ish, 75-ish% range, something like that. So pretty good MRD negative rates there. And when we looked at another trial using obinutuzumab and venetoclax, we also see pretty high MRD negative rates in the peripheral blood, is what I'm talking about here, the peripheral blood being 80%. So overall, maybe 70, 80%. The big question is, right now in 2024, is that going to change the way I treat this patient? The answer is no. It is purely for research purposes, to study, have an idea of how these patients are going to do. We like to say, oh, well, it gives us so much prognostic information. We have no idea what to do with that, right? You could freak a patient out, and they may have been fine anyway, even though they had some residual disease left over. So if you're going to get it, I think peripheral blood makes a lot of sense, but just know that you're really just getting a piece of information that you don't really know what to do with. And the best way to do that is in the research setting, or if you're an academic center or community-based practice, you want to collect a database that's reasonable, but you need to counsel your patients on that. If we get this test, we don't know what it means, right? You still might do very well, and this could cause unnecessary anxiety, specifically when we're talking about that obin-ven patient.
So things like, in this case, a CBC, getting a manual differential, looking at things like that, seeing what the lymphocyte count has done with treatment. Obviously, the clinical component of this, how the patient is feeling, those are the signs and symptoms that we're using to assess whether or not a patient has successfully completed treatment.
Yeah, that's exactly right.
Okay. So going back to this patient, Vivek, I think it's interesting because I think I've gotten this question before too, about combining different sorts of therapies, like combining a BTK inhibitor and venetoclax and obinutuzumab, and also the incorporation of MRD testing in all of this. How do you counsel patients on the use of like a BTK inhibitor monotherapy and the low rate of patients who become MRD negative in that setting?
Yeah, and I think this leads well into the idea of combining everything, right? That if you do BTK inhibitor monotherapy, what we know, 10% of patients will be MRD negative, right? That's not very high if you think about it. Obin-ven, we're like, oh man, let's hit up that 85%, right? But we see really good PFS and OS for those patients on BTK inhibitors, which tells us MRD is not the end-all be-all here, right? That you don't need to have an MRD negative state to do really well. For BTK inhibitors, what's very, very interesting is that we have some emerging data that there may be a subset of patients who can be off treatment regardless of their MRD status, meaning let's say they had 1 in 1,000 cells, not 1 in 10,000, so they'd be MRD positive with 1 in 1,000, or maybe, 1 in 100 or whatever, right? They still have CLL left over, but they've been on years of BTK inhibitor. What happens if you just stop it? And there was a study called the FLAIR trial, and this was a platform trial. We talked about STAMPEDE in the prostate cancer series. The idea here is you have a continuous control arm, which was FCR. Should that be the case as a continuous control arm? Should we amend it? Absolutely, we should amend it, but that's not how we do things, right? And each different arm that was enrolled, the first arm was ibrutinib and venetoclax. That was enrolled from 2014 to 2018. At 2018, that arm stopped, and there's 2 additional arms enrolled, all against a master comparator arm being continuously randomized of FCR. And those two new arms were ibrutinib monotherapy and ibrutinib plus venetoclax, that combined therapy. And this asked the question from the original study, well, what happened when those patients finished 6 years of therapy? The original protocol for ibrutinib rituximab versus FCR was really just stop your ibrutinib at the end of 6 years. And how'd they do? There was a presentation at the International Workshop for CLL in 2023 that said after a year of follow-up, when patients were off therapy, there was a lot of them that did well regardless of MRD status. So it really begs the question of, do you need to achieve MRD negativity to be off treatment? What is the role in that? And we don't know. And the interesting thing is those patients who, so again, they had 6 years of ibrutinib rituximab, then they just stopped and we watched them. They're being enrolled in this trial called STATIC, where it's intermittent BTK inhibitor versus continuous BTK inhibitor. And that's going to be fascinating, right? This idea of retreatment. Can you do something like obinutuzumab venetoclax, have a CR, and then retreat with the same regimen, or a BTK inhibitor, stop for a while, and then retreat? And I think that's going to be a really, really important thing in CLL moving forward.
So it sounds like we have pretty good data to suggest that patients generally do well without achieving MRD negativity, necessarily on that BTK inhibitor monotherapy. Sounds like the jury is still out to a certain extent on if they have sort of stable disease kinetics, as we would call it. Over that time, they might be able to be more intermittent with their treatment as opposed to just staying on it continuously, like you'd said in that STATIC trial. So let's say our patient is still asking us why we aren't interested in combining something like a BTK inhibitor and venetoclax, sort of these two new age oral agents. And we discussed that there is an arm in that platform trial related to that combination. Is there any data out on that approach just yet?
So there are multiple phase 2 and phase 3 trials literally asking this question. What about fixed duration, BTK inhibitor plus venetoclax-based therapies, both prospective single center all the way up to phase 2 and phase 3 trials? And we're going to summarize these in our show notes. So I'm not going to bore you with the details for all these. The bottom line for this is the key that plagues CLL is in all of these studies, the control arm is always some sort of inappropriate chemotherapy that we're not using currently, right? We don't care whether it's this fixed duration versus chemo. We care if it's fixed duration versus BTK inhibitor alone. Is it sequential or combined therapy that's important? And we have not answered that exact question yet. Some of these studies simply had a fixed duration of therapy. For example, take ibrutinib venetoclax for 1 year fixed and see what happens. Other studies said, well, let's use MRD to guide how long we do treatment. So the FLAIR study, for example, that we referenced earlier, that ibrutinib plus venetoclax, what they did there is they said, well, let's check MRD at predefined time points, peripheral blood flow MRD4, the one that we've been talking about that Dan alluded to. This is the one that we're using for CLL, right? And what they did is they said, well, let's say that it took you 1 year to achieve 2 time points of MRD negativity when checking roughly every 3 months. Then we double that time for total duration. So you're on for 2 years. If it took you 1.5 years to reach that, then you're on therapy for 3 years. They just arbitrarily chose something and said, hey, these results look good. That doesn't answer my question. What if we didn't use this fancy MRD technology and just said, give 2 years of ibrutinib plus venetoclax, or give 1 year of combined modality therapy? We don't know which is better. We still don't know that answer. One study that you will see that really tried to potentially ask that question was called the CLL13 Gaia trial. And what they did there is they looked at obinutuzumab plus venetoclax versus obinutuzumab plus venetoclax plus ibrutinib versus chemotherapy alone, with the power for these comparing to the chemotherapy alone arm. Makes no sense why they would do that, but they did. Here's where we are. So what we found, well, MRD rates are higher if you do the kitchen sink approach, but there doesn't seem to be a difference in PFS or OS. So do you really need the toxicity? There was double the rate of grade 3-4 infections. So there's lots of toxicity there. So again, we'll summarize this, but I think really what we want to get at here is that the hopeful future for CLL is that we identify patients who we can de-escalate treatment on. Is that MRD? Time will tell. That we'll find out the answer. Should the kitchen sink approach be what we should do, using MRD adapted approaches, or just do a fixed duration? Maybe that's just as good, right? That should be tested against each other. Is MRD actually useful in a clinical trial, right? You could just say, what about ibrutinib ven for 1 year versus MRD adaptive approaches? Is there any difference? Because why do we need to do all of this MRD testing and all of these things if it's not going to make a difference? And that's the key that we need to figure out in the future for CLL. And the last important thing to note is that MRD testing is not universally available, and it's not ready for primetime standard of care and clinical practice because of these limitations. And you should caution yourself. Don't just order the clonoSEQ because it sounds nice to do. We have no idea how to counsel our patients on a positive MRD result, a negative MRD result. It's not going to change our management. It's for data collection. And I think we need to be upfront with our patients about that.
Vivek, I think that these are such good reminders. I think about this all the time in our AI era, where just because you can does not mean that you necessarily should, And so I think that this really highlights that there's a lot of really important work being done with MRD, and not just in CLL. I think we see it. You go to ASCO, you go to ASH, they're asking this question in so many different disease types. But in the same way that even in breast cancer, we were talking about the role of like PathCR and what the role of PathCR is in terms of long-term outcomes for patients. We just don't know. And as Vivek had said very eloquently in those discussions, the idea is that it takes a long time for us to get things like overall survival data and progression-free survival data. So if we have other surrogates that can allow us to basically get that answer quicker, then that means that we have data that we can utilize for clinical practice for the prime time a lot faster. But we are at this exciting time where all these discoveries are being made, things are happening, but we just don't know what to do with that information just yet. So all this to say, in February of 2024, we've certainly made a lot of progress, but I'm sure in a few years, hopefully we'll be able to do more with this information.
Yeah, and I really want to highlight something that you said about the surrogate endpoints of something like a PathCR, or in this case, an equivalent concept of MRD negativity, that it depends, right? What if you checked too early and you found an MRD negative state, but you didn't look for it being sustained? Then you're wrong, and you could have a disease relapse, and you could have undertreated a patient. What if you checked too late? Maybe you had a window earlier that you could have de-escalated therapy. What if your level of assay of detection was just too sensitive? Do you really need 1 in a million? Why not 1 in 10,000? Which is better? What about the peripheral blood? What about the marrow? And all of these questions makes it very clear that we still don't know what to do with this data, like Ronak said.
Well, guys, I think this is a fantastic discussion. I think that we have discussed a lot of important hot button topics in CLL, on top of providing our listeners with some great information about how to take care of these patients that have CLL. So I don't know if any of you have any final thoughts other than everyone should watch Love is Blind, but anything in regards to CLL?
No, I think we've made a good point here that we need to use caution when we're approaching some of the latest and greatest things that we're hearing about on the cutting edge of some of these disease treatments and disease management, and MRD and CLL is just a fantastic example of that.
This is awesome. All right, guys. Well, then I think that wraps up another fantastic episode of The Fellow on Call. Until next time, we'll see you all later.
See you later.
Peace.